I'm Rob Williams, I'm an interventional radiologist. I'm going to talk to you today about treating a simple common iliac artery lesion with angioplasty and then possibly stent if required. This is a middle-aged man who has short distance claudication affecting his lifestyle and work. We have CT imaging which shows a focal tight right common iliac artery lesion. We've already inserted a sheath, a catheter and a guide wire. We know we're going to be treating this lesion, so it's perfectly acceptable to insert the 6 French sheath at an early stage. We've crossed the lesion based on the imaging we have already had. I'm now going to insert the pigtail catheter into the distal aorta past the lesion, remove the guide wire, and we'll do a subtracted diagnostic angiogram, 20 mils of contrast at 10 mils a second. And there we have a demonstration of the lesion. Okay, we'll stop that and we're going to take that as an overlay and give us some guidance on treatment. We've measured up from the CT scan. We know that the diameter of the normal vessel is about 8 millimeters, and therefore we're going to use a simple 8 millimeter by 4 centimeter balloon. Just going to fade that image out a little bit. I'm going to reinsert the guide wire. Try and keep the tip of the guide wire in view if you can. It's a J-tip, so it's very safe. Okay. So we're now going to insert an angioplasty balloon, an 8 millimeter by 4 centimeter balloon. This will go through the 6 French sheath. You can see it appearing over the guide wire. We'll apply a little bit of our overlay from our reference, just to make sure we get the positioning of the angioplasty exactly right. Fade that out and we'll inflate the balloon. You need to know your equipment and the rated burst pressure of the balloon. See the balloon dilating up and the lesion dilating. And the rated burst pressure is 14 atmospheres, and then we've had to go up to about 10 atmospheres to actually dilate this lesion. We normally maintain inflation for about 2 minutes. Interestingly, as we deflate the balloon, we can see the patient's heart rate has gone up significantly and is starting to experience a drop in blood pressure. It just raises your suspicions that all may not be well. In fact, the patient is reporting quite significant back pain and flank pain, particularly after the balloon was deflated. So I'm now a little bit worried. I can see that the blood pressure is dropping. I'm going to take the balloon out and try and do some imaging fairly quickly. But important, in fact critical, is you leave the balloon on the guide wire at this stage. Don't take it off the wire. So we're just going to inject through the sheath. We don't need to be above it. And we're going to inject hard. And in fact you can see contrast extravasation. The patient's bleeding from the midpoint of the treated vessel. So we've got a problem here. This patient has ruptured their common iliac artery, and at this stage you need to work quickly. Now generally we're treating patients who are awake. They start to get uncomfortable, but you don't want to alarm them too much, but you also need to alert the rest of your team that there is a problem. The first thing to do is to reinsert the balloon that you have fortunately left on the wire and do a relatively gentle inflation across the lesion. This is the balloon that's caused the rupture, but can also occlude most of the flow across the vessel, and it may not completely obliterate the bleeding, but it can stabilize the situation and give you time to think about how you're going to deal with this rupture. First step if you're not a vascular surgeon, is to ring one and alert them that they may need to free up an operating theatre. Your ultimate bailout is laparotomy and repair of the vessel. But generally speaking, you can bail yourself out with endovascular techniques. So we need to select the appropriate size covered stent. We know that the vessel is 8 mm in diameter. We only have balloon expandable stents. Therefore, we use an 8 mm diameter, 4 cm long stent to cover the lesion. Okay, so what we need to do now is deflate this balloon now the equipment's ready. Remove the angioplasty. So at this stage the patient is bleeding again. We need to select our covered stent, 8 mm by 4 cm, and we also need to insert a larger access sheath, because these sizes of covered stents will not go through a 6-French sheath. So again, leaving the guide wire in place, that's critical, and we're going to change our sheath to 7 or 8 French sheath. Take this up and pass the lesion. Working as quickly as you can, insert the covered stent. It's a good idea at this stage to mag up and to do another hand injection to confirm accurate positioning. Okay. I think what we'll do is we'll try and repeat that run. We need to get this stent positioned accurately. There's no point rushing and getting it wrong. There we go, a better view of the rupture. Okay. And we're going to use that as a reference overlay. And just fade that out for the moment. Uncover the balloon expandable stent, fade in, confirm our positioning, and deploy the stent. Go slowly and up to the nominal diameter again. Reference the literature that comes with the balloon mounted stent. It'll tell you the diameter you gain for any given pressure. Deflate the balloon. At this stage, best thing to do, if you can inject via the sheath, is just advance it up past the balloon again. Repeat your angiogram from above. That confirms we've achieved hemostasis. There's no longer any bleeding from the vessel, and that we can remove the balloon. And as a final act, it is sensible to do a flush aortic angiogram, just to double check.